Hello. So today we're going to be talking about MR imaging in multiple sclerosis. So the first thing that we want to discuss in MR imaging for multiple sclerosis would be the McDonald criteria for dissemination in space and dissemination in time. Okay, so when we're talking about MR in MS, so what we are essentially trying to describe is the pattern of white matter lesions in the brain or in the spinal cord. Okay, so when there is any patient who's got an MRI for any reason and there is a white matter lesion in that MR, the by far the most common cause for those white matter lesions would be small vessel disease. There's a study that says if there are 1 lakh patients who've had white matter lesions in their MR, about 500 to 50,000 of those patients would have small vessel disease and only about 100 patients would have multiple sclerosis. Okay, so if there is a patient who does not have any clinical suspicion for MS and he has white matter lesions, then it would be inappropriate to suggest MS in that patient's MR. But if the patient is clinically suspected to have MS and you have white matter lesions in the patient's MR, that is where our McDonald criteria would be useful. So the first thing that we look for is dissemination in space of those white matter lesions. So what does that mean? 1 or more T2 lesions in at least 2 out of these following 4 areas of the central nervous system: juxtacortical or intracortical, periventricular, infratentorial, and spinal cord. When we are looking specifically at the periventricular lesions in elderly patients or patients with cardiovascular risk factors, atherosclerosis, hypertension, diabetes, hyperhomocystinemia, atrial fibrillation, all of these things, it is better to consider more than 3 periventricular lesions instead of just more than 1. Okay, so that was dissemination in space. We will look at each of these specifically later. The second thing is to demonstrate dissemination in time. What does that mean? You can either demonstrate dissemination in time with one baseline MR and then a follow-up MR, or you can demonstrate different ages of lesions in the same MRI. So how do we do that? We use 2 sequences. One is T2 and one is contrast enhanced sequencing. So the contrast that we use in MR is gadolinium. So if you can demonstrate a lesion, a T2 lesion or an enhancing lesion which was not present in the patient's baseline MR, then that is suggestive of dissemination in time. Or if in the same MR you can see that there are enhancing as well as non-enhancing lesions, then that means those 2 lesions have been there for in 2 different periods of time. Okay, so enhancement of an MS lesion usually is there only for 1 month. So if there is a non-enhancing lesion and an enhancing lesion, that means they have occurred at 2 different periods of time. So that is how you will demonstrate dissemination in time. Okay, so now let's look at what these areas or locations actually look like. So this is juxtacortical. So here this is a T2 sequence. All of these I believe are T2 sequences. Yeah. So here we have this is the cortex. In a T2 sequence, the white matter is going to look dark and the gray matter is going to look bright. So in the periphery of the brain you have the gray matter, and here this is the white matter. So these white lesions, right, they are well opposed to the cortex of the brain, so they are called juxtacortical lesion, and some of them can be intracortical also, although these are juxtacortical lesions that we're seeing here. Okay, so it is important to differentiate juxtacortical lesions of MS versus small vessel disease. Like I said, small vessel disease is far more common, and in a patient with white matter lesions they are more likely to be small vessel disease. So how do you differentiate? Here you see this gray area, all of these gray areas are the gray matter. Okay, so this white area is involving subcortical U fibers. It is very well opposed to the cortex. Okay, that is classical of MS. Whereas in small vessel disease there is this dark band between the cortex and the white matter lesion. So in small vessel disease the subcortical U fibers are spared. Alright, so you have to look at this for differentiating between MS and small vessel disease. Okay, so that was about juxtacortical lesions. The next is periventricular. Periventricular white matter lesions are usually oriented perpendicular to the ventricles. So the characteristic Dawson's fingers that we have seen, usually you must have seen it on SAG. I'm showing it in axial here. So here these white matter lesions are located perpendicular to the ventricles, right? Why is that? because MS demyelination occurs along the medullary veins. These medullary veins, which are small, they are oriented perpendicular to the lateral ventricles. So that is why the white matter lesions are also perpendicular to the ventricles. So those are periventricular lesions. And the fourth location is infratentorial, which is the brainstem and the cerebellum. Usually they are small lesions and they're located peripherally. And the fourth, of course, is those in spinal cord. We look at the criteria for spinal cord separately. Okay, so juxtacortical, periventricular, infratentorial, and spinal cord. So here in infratentorial pattern, again it is important to differentiate between small vessel disease and MS. This is small vessel disease, this is MS. In small vessel disease, you have a central and a kind of a transverse pattern, and that is involving the pons, the central pons. Whereas in MS, you have a very small white matter lesions, very small white matter lesions, which are located peripherally. They are sort of triangular in shape. Okay. So it is important to differentiate between MS and small vessel disease. Another condition that we have to differentiate from MS, which is involving the brain, is tumor. It's a brain tumor. Okay. So here you have this obvious T2 in hyperintense lesion involving the temporal lobe and probably some of the occipital lobe as well, the parieto-temporal and the occipital lobe, right? So there is some perifocal edema also, and this is a T2 T2 weighted image, and this is the post contrast image. Okay, this is at one level cranial to this, and again this is the corresponding contrast enhanced images. Okay, so what we are trying to see here is this T2 hyperintense lesion. Any T2 hyperintense lesion means that there is some kind of water content within that, or there is some edema within that, right? But what you see on the enhancement pattern is that it is not completely enhancing. So if you are thinking of a glioma or any kind of high grade glioma, then the enhancement is supposed to be heterogeneous and it is supposed to be complete. But here the enhancement is only in a part of the lesion, only here. These white areas are enhancement, so only this part is enhancing. Okay. And the second thing is there is no obvious mass effect. What does it actually mean? This is a case of a brain tumor, so this is a glioma, a high grade glioma, that is. So what is happening when there is a space occupying lesion in the brain? It is going to displace the adjacent structures of the brain, right? So you can see that these the sulcal spaces on this part on the left cerebral hemisphere, they are all effaced. Here you can see the sulcal spaces nicely. Here they are all effaced. Also, since there is a lesion over here, it is occupying some space, it is going to displace the other structures. There is effacement of the ventricle and there is midline shift also. So this is called mass effect. Whereas here you can see that the ventricle, although it is a little small, maybe it's encroaching upon the ventricular space, but there is no effacement of the ventricle as such, and there is absolutely no midline shift. Okay, so that is telling us that this is actually not a mass. This is just a demyelination. Second thing is you can see this heterogeneous enhancement, and it is complete throughout the lesion. Here it is incomplete enhancement. That is called an open ring type of enhancement, and this is called tumefactive demyelination in MS. Alright, so that is an important thing that we have to differentiate from a brain tumor, and it can look very similar. Alright, so now we come to spinal cord involvement in multiple sclerosis. So yes, it is present in majority of MS patients, around 85% in patients who have MS present very early, and typically they are peripherally located, they are wedge shaped, they are short segment. What do you mean by short segment? It is involving less than 2 vertebral segments. Okay, they are cigar shaped, and sometimes there can be cord edema or myelomalacia, which means cord atrophy. Spinal cord lesions don't enhance commonly, and it is more commonly present in the cervical region compared to the thoracic. So this is a schematic diagram that talks about the pattern of involvement, spinal involvement in MS and other conditions. So here you can see that it is wedge shaped, either in the dorsal cord or present laterally. Very uncommonly, it can involve the anterior cord as well. Okay, so it is a mimicker of all other diseases. It can present in any pattern, but the consistent features are that it is a short segment involvement, and it is usually small and triangular and peripheral in location. Alright, So here is a typical case where the cervical cord is involved. Again, very small, dorsally located. Axial sections are very useful for any spinal pathology. So here you can see the dorsal cord being involved. It is wedge shaped, and again very small. It is involving only a portion of the C2 level. Okay. Again, this is spectrum of spinal cord involvement in MS. Peripheral location, wedge shaped, small, right? Lateral involvement can also be there. Again, this is dorsal involvement, lateral, lateral, and again dorsal and lateral, dorsolateral here. Okay, so that was the type of location